skin also. The skin graft that they had put on the, there were multiple sinuses, the mesh was exposed, multiple sinuses, there was practically no skin. So we were left with two options. Otherwise the colostomy was alright. So we had to do one was that we were placing the mesh almost on the peritoneum, so on the gut. So we had to use one of these tissue separating meshes. But the more important problem was that we had to use the TFL flap to actually provide for the skin, because the entire area was full of just a grafted skin with multiple sinuses, which could not have been used again. So that is why, and since the entire area was gone, we would have had to then do maybe either an ileostomy or a transverse colostomy, because otherwise there was practically the entire area was gone. There was no place to reside the colostomy. In fact, recently we have done another case. In fact, that case was originally operated by me 20 years back for a radical cystectomy for a bladder cell carcinoma, and he had received radiation and 3 times partial cystectomy was also done. So he came with a similar kind of hernia and around the ileostomy, and we again have done a similar kind of thing for him as well. But that was done 20 years back, and the skin was completely radiated. Once again, the skin was very bad. So basically the two problems. One was this multiply recurrent hernia with practically nothing in the abdominal wall, and of course the infection being there, and then there was no skin cover. So we also have to provide the skin cover as well as strengthen the abdominal wall. And so resiting around that place would have been impossible. We would have then had to do a transverse colon or ileostomy.
Yeah, that would have been much easier, or maybe further recurrences would be prevented.
But this patient is there for about 1 year so far. He is at least doing very well. He has come recently also for a follow-up with us.
Yes, if it goes well.
So far he is doing well.
Definitely.
Frankly speaking, I have not got very much experience about PSH. But being a thesis examiner, I had received a few thesis materials regarding the colostomy and parastomal hernia in case of the anorectal malformation from the pediatric surgery. So parastomal hernias are more tackled by the pediatric surgeon than by the general surgeon. One point. And second point, how the abdominal wall integrity is done by the oblique muscle or linea alba. It is said that the linea alba, gentlemen, there was a Hunterian lecture, the linea alba varies from person to person, and the crisscross anatomy is different from one person to another. So as the complicated cases, the overlaying scheme was abnormal. The patient had a abdominal dissection about 14 years back, and then skin has become devitalized and the atrophy. I think without doing a reorientation of the stomach, by removing the skin and covering by the skin is a more wise proposition than forming a new stomach. So I will move along with Malhotra than with Professor Shah.
Okay, thank you. So,